Our next speaker is Dr. Lindsay Cox. Dr. Cox is an assistant professor in the Department of Urology at the Medical University of South Carolina. She graduated magna cum laude with her Doctor of Medicine from The Ohio State University, where she was elected to the Alpha Omega Alpha Medical Honor Society. She completed urology residency at the University of Pennsylvania. She received her fellowship training in female pelvic medicine and reconstructive surgery at the University of Michigan. Dr. Cox is board certified in both urology and female pelvic medicine and reconstructive surgery. As a reminder, there will be time for questions and answers after the session. Please type your questions in the Q&A feature at the bottom of your screen, and we will try to get to them all.
Okay. So we're going to talk about some issues related to spina bifida and sexual health. And I wanted to note a few things. So I have no personal disclosures related to this topic. And there are going to be some anatomically accurate diagrams and medical language used. So if there are younger children or not age appropriate people in the audience, now would be a good time to either mute your screen or use headphones, or you can not view the slides and just listen. So I'll give everybody a second to catch up with that if you need to. One of the things that people wonder about, and I think societally, viewing people with disabilities as asexual is one of the major problems that we find in the literature, and that even physicians don't view sexuality as an important topic to bring up with patients and their families. But we do know when people are surveyed that up to 48% of young women with spina bifida are sexually active by age 25. And beyond that, 92% are interested in becoming sexually active, and over 75% are interested in having children. But really, there are very few conversations that are happening between young people with spina bifida and their physicians. In spite of all of the doctor's visits that you're attending and going to, this is not a topic that is broached. And when patients are asked why they don't bring it up, they feel the provider might dismiss their concerns, or that the provider themselves might be uncomfortable beyond their own discomfort. And so very many of the discussions will only happen if a provider is comfortable bringing up the issue of sexual health. And this is not just patients with spina bifida. This is across the board, that the American Congress of Obstetricians and Gynecologists say that these conversations should really be occurring by age 13 to 15 years of age, before patients are becoming sexually active. And there's really been kind of a shift to media, including social media, but also into shift from physicians and pediatricians to public schools for sex education, and where sexual health is sort of brought up. And one of the problems with that is that there's a lack of specific sexual education related to spina bifida. So even though young people are going to receive a lot of information from sex ed in school, from their peers, from the media and parents, that's different from the information about spina bifida as it relates to sexual health that you can get from a healthcare provider. And so really opening the doors for those discussions is one of the goals, but also seeing that the healthcare provider community is interested in meeting people's goals of having a meaningful sexual experience, as well as goals related to pregnancy and fertility. And then the other reason to have these conversations, there are some other benefits. So preventing unintended pregnancies. So as was just mentioned in the previous panel, that there are people who aren't aware of their fertility potential. And some patients are not using contraception that probably should be. Managing pregnancy and delivery complications. So again, with patients who don't have the knowledge and haven't spoken with their healthcare providers before achieving pregnancy, some of the things that may be considerations for how to go about caring for yourself, self-care and beyond, once you do become pregnant. Preventing sexually transmitted infections. So sexually transmitted infections are not a problem that has any kind of barriers for any specific population. And preventing unwanted sexual contact. So there are certainly ways to educate young people about what's appropriate and what's inappropriate, and unwanted sexual contact and even sexual abuse is something that if you aren't asking about and aren't having conversations about, can go unnoticed and can be harmful. Other sort of general considerations. So one of the other barriers to having these conversations with your healthcare provider can be how time consuming and focused people are on your bowel and bladder dysfunction. Most patients with spina bifida that are transitioning into adolescence and adult care are transitioning within the field of urology, which I'm a urologist. But a lot of times, most of the questions that we're asking are about your bowel function, your bladder function, and that this takes up a lot of time. This is where a lot of our surgical focus is. And so the transitional care appointments can end up missing out on some of the other more nuanced topics, including sexual health. The other considerations are the dependence on caregivers. So even in some of these transition appointments, and most of the patients who are young enough to be coming to an adult urologist in their early years are coming with parents. And so sometimes these are topics that if patients are coming with parents, they don't necessarily want to talk about, or that the provider feels uncomfortable bringing up in front of parents. And that lack of privacy certainly comes with some benefits, and having the parents there as advocates and as well as allies for patients, but it also can be a detriment to some of the more sensitive topics and things that the patients don't always bring up with parents or caregivers there. So we'll start with talking about male sexual function. So overall, when you look at surveys of patient groups, and the patient groups that are surveyed are different, and they're from all over the world, but in general, adult men with spina bifida report lower satisfaction with their sexual life than adult women with spina bifida. And there's probably a few reasons for that. And some of it has to do with the actual deficits and the variability, and some of it has to do with kind of the treatments and what makes sexual encounters satisfying. So normal sexual function kind of follows a cycle. It starts with something that people will have heard of called the libido, but that's essentially desire or motivation for sex. And that's sometimes can be a little bit challenging in terms of where people are with their healthcare status, what their health-related quality of life is, other things like depression, anxiety, can all play a factor within that desire or motivation to be interested in sex. Arousal is the next phase. So the actual physical ability to become aroused in men leads to erection, so penile erection, and then orgasm or climax, ejaculation or the actual expulsion of the sperm, and then resolution. And so normal function in males, we'll see when we look at the male anatomy, is very much tied to the nerves, and there are spinal reflexes that act in order for these steps to occur. And so you can see based on the spinal level, everything sort of T12 and below, so the thoracic, lumbar, and sacral spinal cord levels all have something to do with sexual function. So impairment in any of these areas can lead to changes in the sexual function. And the changes in a system this complex are not always predictable. And one of the hypotheses that comes with the idea that men have less satisfying sexual lives than women with spina bifida is that the complexity of this and the unpredictability is part of what leads men to not always be able to have treatments that work for everyone. And so when we talk about treatments for sexual dysfunction, sometimes there's a stepwise progression that you have to go through in order to have success. So all of these nerve inputs are important in sexual function, and some of them can be overcome by treatments and some of them can't. So potential problems, and I touched on this a little bit, but desire and motivation to have sex can have something to do with your hormones. Now, that's not to say that spina bifida itself causes problems with male hormones. About 90% of men who've been tested with spina bifida have normal testosterone levels, although obesity does play a role in that. So men who are obese tend to convert their testosterone to estrogen. And so obesity can play a role in having abnormal hormone levels. And so, you know, just like being healthy in other aspects of your life, your sexual health can be impacted by being overweight or obese. Erectile dysfunction is common. Around 50% of men who are answer surveys sort of across the board with spina bifida have some problems with erections. Most of the problems have to do with the erections not being as rigid as would be desired for intercourse, but difficulty in maintaining an erection is also a major problem. So spinal reflexes that allow erections to happen don't always allow for the completion of a sexual act. And so a lot of times medications can both improve the rigidity of erections and help maintain an erection for a longer period of time. And so about 80% of patients who have erectile dysfunction with spina bifida will respond to medications like Viagra, Levitra, Cialis, and those medications, in the absence of other medical problems that are cardiac in nature or have to do with your blood pressure, are safe to take. They do have some side effects, but in general, men who take those medications to have sex report very satisfying sexual encounters, and really do find that the medications improve their erections to the point that they don't have any problems having a healthy sex life. Decreased sensation is another issue. So sensation around the genitalia is important to be able to have an orgasm, and is sometimes important in terms of the feedback of the spinal reflexes to have things like erections and ejaculation. And so when those things are decreased, there has to be some adaptive responses that patients need to individualize to their own body as to what works. So for example, I have some patients who have decreased sensation where vibration is very helpful. And so using a vibrator to help with sensation problems. Retrograde ejaculation is fairly common as well. So normally the semen, as the ejaculation happens, is pushed out of the urethra with some force using the muscles that surround the urethra and the penis. And so if those muscles' strength is impaired, or there is not a closure of the bladder neck behind where the ejaculation starts and where it needs to come out, you get what's called retrograde ejaculation, where the semen, instead of coming out of the penis, either all goes back into the bladder or comes out with such lack of force that it almost just drips out. And so retrograde ejaculation itself is not harmful or unhealthy. So not having a forceful ejaculation isn't a health problem, but it can impair fertility. And so when the goal is to deposit the semen into the vagina to make a baby, the retrograde ejaculation does become an issue. Incontinence is another problem that we see quite frequently. So male adults with spina bifida who have incontinence tend to have lower scores on those sexual satisfaction surveys. And so management of incontinence and the issues around continence, bowel and bladder, can have an impact on how someone's sexual health is perceived by the patient as well as the partner. And there's also positioning issues. And so patients who already have pain and who have some spinal issues and potentially are not able to accomplish what would be, quote, normal sexual positions have some adaptive things that may need to be done to have successful intercourse. And not everyone's aware of how successful those things can be. And so we've actually worked with some of our physical medicine and rehab doctors, as well as occupational therapists that can be helpful with this. But again, that conversation needs to be had with a healthcare provider in order to talk about what the resources are to help with adaptive positioning, to help with pain that may impair someone's ability to have a satisfying sexual encounter. So switching gears a little bit to females. So desire, motivation, libido, again, the same kinds of things. So we always talk about, the biggest sex organ is the brain. And so issues with things like depression, anxiety can also impact your sexual function and your sex life, as well as your perception of that. The normal function in females, it does kind of have that same reliance on spinal levels, and different parts of the spinal cord do permit different parts of the process to happen. So arousal and vaginal lubrication is coming from a thoracic level. Orgasm and the contractions that are sensed, and the sensation for the female, that are coming from the sacral levels. And then resolution after the sexual activity, again, kind of positioning and pain, incontinence. Those are all things that kind of play a role in normal function in females as well. The female anatomy, though, in spina bifida, after we take consideration away from sort of bony and pelvic and spinal anatomy, is normal. And so fertility potential for females who haven't had any surgical alterations of their anatomy is normally formed to have fertility. And so a lot of learning about the menstrual cycle, the fertility potential, as well as the need for contraception, should be happening in patients as they reach the age of puberty, which in some studies has been shown to be slightly early in the spina bifida population, so in young females. So in that 11, 12, 13-year-old age range, where people are starting to experience some of the normal parts of maturing and puberty, learning about fertility is a really important step. And there are some barriers to adolescent gynecologic care in general, just in terms of access to that resource. But this is something that should certainly be brought up and would be appropriate to be talked about with the general practitioner, family medicine doctor, contraception, and as well as your urologist. Potential problems. So sensation problems, again, there are some sensation differences, but about 80% of women report having some genital sensation, 80% of women with spina bifida. Whether or not they're able to achieve orgasm is one of the more variable parts of the condition, and is a little bit individual. And sometimes it takes some learning and education in order to be able to do that with the sensation that you have. Lubrication can be an issue. So especially if you have a lack of sensation, lubrication can be really important, and using lubricant in order to prevent tearing, ulceration, friction, rubbing problems during intercourse can be a major consideration for intercourse. Again, with incontinence, so managing bowel and bladder how bowel and bladder are managed, what types of situations, what types of activities do you tend to have leakage of stool or leakage of urine, and managing that with regards to having intercourse. In terms of kind of general advice, a lot of patients that I've talked to who have been successful with this do things like a fluid restriction. So if they know that they're going to be intimate, they will not have as much to drink for a few hours beforehand, or they know that what their cathing regimen is and they'll make sure to cath right before. Pelvic floor muscle tone is another issue that kind of has to do with, again, positioning and it's sort of whether or not intercourse can be comfortable and satisfying. So learning about the pelvic floor and pelvic floor muscle tone can be helpful. And we have pelvic floor physical therapists, so specialists who work specifically with the pelvic floor that can help with issues related to that. So people who have high tone pelvic floor might need some help with muscle relaxation versus people who have a low tone pelvic floor, and knowing that. And then things that can be painful as far as intercourse and making sure that the problems and partner issues are brought up and dealt with, and something that if there's a problem that can't be overcome, almost all of the information is on Google, but there is a problem that can't be overcome just with education, then bringing that up with your doctor and actually talking about, hey, this isn't working, or we can't have intercourse because of X, Y, or Z, this type of bone problem, muscle problem, spasm, curvature, whatever it is. Those are all things that have answers and can be brought up with a healthcare professional. Lastly, I wanted to touch a little bit on fertility and contraception, and I will have another disclaimer here that I'm not a fertility specialist. So we do have fertility specialists both on the male and female side, where I work at MUSC, that work with patients on planning for family planning. So whether it's trying to conceive or trying to avoid pregnancy, but also considerations for pregnancy and delivery. Fertility concerns in men can kind of stem from that ejaculation issue. And so we do offer, from a urology standpoint, some advanced techniques for sperm extraction, so that even if men can't have intercourse to achieve a pregnancy, sometimes sperm extraction alone, if their partner's fertility is normal, is a fairly simple way of overcoming that barrier. We talk about contraception, in terms of men being part of the conversation for contraception and using condoms, whether it's the male or the female partner that has spina bifida, using non-latex condoms and knowing what's in any materials that you're going to use, be it vibrators, toys, otherwise, and things that you're going to be in contact with, having latex if you're latex sensitive, and avoiding it. Use of things like contraceptives with hormone manipulation, risks for blood clots, and things like IUDs and risks for infections are certainly things to talk about with your OBGYN. And I'm not an obstetrician, so I don't deliver babies or take care of pregnant women, but we do definitely see patients who are pregnant with spina bifida in the terms of having a urologist essentially attend deliveries, that whether they're vaginal deliveries or C-sections, to help manage some of the surgical concerns and any issues that might come up with catheterizable stomas or augmented bladders, or managing patients with artificial sphincters or other urethral problems in and around the time of pregnancy and delivery. And current recommendations are for vaginal delivery if possible, and avoiding, especially in patients with shunts, avoiding entry into the abdominal cavity if possible. Although with prophylactic antibiotics and usually with a team potentially having it being safer under general anesthesia, C-sections are certainly done. I've attended several of them for patients that I share at MUSC to help manage things like bladder augments or catheterizable stomas and help keep those safe at the time of delivery. And there's certainly collaborations that happen, but I think that the general concepts are that talking about these things early and on and having a plan before they happen is certainly an easier way to deal with things than to deal with unintended pregnancies or pregnancies and deliveries that where we haven't made a plan, and a collaborative plan with a multidisciplinary team is usually the approach that we prefer. I wanted to leave a whole lot of time for questions, and so I'll open it up, but I wanted to just let the association know and all of the participants that I really appreciate the opportunity to talk with you today, and I think this is an important topic, and one that I think that healthcare providers are certainly receptive to listening and to hearing more about. And you know, for people who are brave enough, hopefully, to ask some questions, I'll try to give you some good answers.
Thank you so much, Dr. Cox. This was such an important session, and like you said, sometimes you know, we can all be a little bit hesitant to talk about these things, but it's so important. And you do have two brave people who have questions. But we have other questions as well. And it's the one person wanted to know, how likely is injury to the vagina or the perineum or the urethral opening for a female with spina bifida during sexual intercourse due to the reduced sensation?
So it's relatively unlikely. The vagina itself, the tissue is designed to pass out a baby. So when we talk about something in your body that's able to stretch well beyond what you would expect it to, we see some injuries in patients that are, you know, due to sort of chronic issues. So you know, I had a patient who masturbated a certain way with a certain type of device all the time and had basically pressure in one place. And so that's could be an issue, but, you know, I think as part of all of your self-care, one of the things that you need to do is monitor, you know, areas of your body, especially where you have decreased sensation, and the vagina is one of them. But I would say, particularly with using lubricants and, you know, having a partner that is participating with you, you know, a lot of times that will be something that when we sit down with couples, that especially a male, an able-bodied male with a spina bifida female is worried about. And so oftentimes we kind of go through almost, you know, how to do an exam and look and see and make sure that they feel comfortable with what they're doing and not hurting anything. But in general, all of those tissues are well vascularized, stretchy, very rarely injured, and they're designed for sex. And so, and they're designed for parturition, you know, having babies. And so I would say overall low risk, but something that certainly should be on your radar in terms of monitoring, especially with a supportive partner.
Oh, great, thank you. Is the risk of UTI in sexually active women with spina bifida increased?
Yes. So any woman who is sexually active has an increased risk of a UTI, spina bifida or not. And so we oftentimes find that it doesn't have, we have a lot of wives' tales about UTIs that exist out in the community. And oftentimes, you know, it's hard to separate what the correct medical information is in general, having intercourse increases your risk of UTIs, and that's across the board. But there are certain people, and this doesn't have anything to do with spina bifida or having an abnormal urinary tract, there are certain people who just have a propensity for the type of bacteria that are moved around during sex to get into the bladder and cause an infection. We think it probably has to do with their genetics, and it has to do with their body's ability to hold on to bacteria. And so once the bacteria find their way in, because of things getting moved around during intercourse, then it's up to the body's defenses to get that bacteria out. So for example, someone who caths has bacteria in their bladder all the time. We expect that. So catheterized bladder without bacteria would be relatively unusual. And so when there's bacteria around, a lot of times the next step in forming a UTI has to do with pressure. And so keeping the system drained, keeping the system empty, which is, you know, the same recommendation for a spina bifida patient that we would make for anybody who voids on their own, is to keep that system empty, keep that system flushed out as much as possible before and after sex. There are some patients who just have a low enough threshold for UTIs that intercourse pushes them over the edge frequently. And sometimes we'll give a low dose of an antibiotic around the time that people have sex just to prevent that.
Okay, thank you. Can you direct us to some resources for sexual health specifically in spina bifida?
So, you know, other than the medical literature, I don't know that, and the association may actually know more about this than I do. You know, we do a lot with patients on an individualized basis. And so, you know, talking with your urologist, your OBGYN, your physical medicine doctors about adaptive things in sexual health. But I don't have any formal resources. I know the NAFC, the National Association for Continence, does have some information about sexual health, but I don't think any of it's spina bifida specific. It's more about sexual health with stoma care, with catheterizing and things like that.
So the Spina Bifida Association actually does have a set of guidelines that were written for people across the lifespan, ages across the lifespan, and one of them is on sexual function. So you can find it on the Spina Bifida Association website. Just go to spinabifidassociation.org. In the search bar, type in guidelines, and then you'll see the guidelines for the care of people with spina bifida. And then from there, you can look at the PDF and look up sexual function, I think it's called. And then another question, we have all kinds of brave people, Dr. Cox. For a woman with spina bifida who is not currently sexually active, when should she have a pap smear and exam, and who should she see?
So routine gynecological exam is recommended for once you reach the age of 18. Generally speaking, if you meet with either your family doctor or an OBGYN and talk to them about, you know, risks, most of the reason people are getting pap smears are looking for things like HPV, but there are certainly other reasons to have a routine gynecologic exam and discuss things like folate supplementation, for example, if you're planning on becoming sexually active, talking about contraception. And so I think starting with a primary doctor, family doctor, but you know, it wouldn't be uncommon to see an OBGYN at the outset to have that exam. But usually upon, you know, reaching sexual maturity and adulthood, I think it's reasonable to take that on as part of your sort of responsible look at your sexual health overall, and taking that on as, you know, one of the things that lucky enough to be a woman we get to do and have that annual exam. So
just random question related to that. If if you're just not having sex and you don't see it in your foreseeable future, should you still have the pap smear and the exam?
I think it's reasonable to have one. So have a first one and make sure that everything is healthy and that there aren't any concerns, so that it wouldn't be a surprise to you if in the future, plans change. But also, it's one of the areas where things can be overlooked. And so I think having that first initial baseline exam, and then you and your doctor have a conversation about whether or not this is something that needs to happen annually or every other year or every 5 years. And so a lot of that can be individualized once you develop a relationship with somebody and you've opened the doors to the conversation.
What is the impact of bladder neck closure on overall sexual function?
So bladder neck closure can help with incontinence. And so oftentimes if the bladder neck is just not salvageable in terms of continence mechanism and the bladder neck is closed, if it's closed surgically without any type of implanted device, then the impact on sexual health would be minimal, other than it would be favorable that we potentially have a less likelihood of having incontinence through the urethra during intercourse or around the time of sexual activity. If the bladder neck closure includes something like an artificial urinary sphincter device, that can be a concern in terms of kind of going back to the previous question, pressure, ulcers, so pressure and manipulation of the area around that device. And so in women, the use of artificial urinary sphincters is less common, but we do still see some people who have bladder neck continence achieved by an artificial sphincter device. And where that device is placed, is right between the urethra and the bladder, and then the vaginal wall. And so that vaginal wall, we would need to make sure that there was good tissue integrity and that there was no problem where the device could erode into the vaginal wall from trauma, not trauma in a bad way, but trauma just related to normally having intercourse.
Thank you for that. Is uterine prolapse more common among women with spina bifida?
So we don't see a lot of patients with spina bifida with uterine prolapse. When a lot of the conversations that are had around prolapse, prolapse is really a phenomenon of sensation. And so oftentimes, even people who have a slight degree of prolapse wouldn't know about it. And we generally only fix prolapse when prolapse is causing a problem. And so we rarely see women with spina bifida coming in with prolapse that's causing a problem. And so what would those problems be? If the vagina starts to come out, or the uterus is coming out of the vagina and there's no sensation there, then you can get things like ulceration of that tissue. So the same kind of pressure sores that you can have on any other tissue, especially where you're sitting. But generally speaking, we're not fixing a lot of prolapse in patients with spina bifida. Some of that probably has to do with abdominal pressure. So you're probably not generating a whole lot of abdominal pressure. And so that same reason we don't see it a lot in patients with spinal cord injury. So that process is probably less frequently happening. We do see it some in patients who have given birth with spina bifida, and a lot of times that's something that we monitor. It's less frequently a surgical problem.
Great, thank you. Next, we have a couple of questions that are somewhat related to each other. So I'll read them both. I think they're somewhat related. How can parents help to breach the topic of sexuality for adolescents with healthcare providers? And how do healthcare providers get over the barrier that parents might pose in terms of privacy on that topic?
Yeah, I think all providers at some point should have conversations with their patients without the parents present, if that's something that makes sense for that individual patient. So, I oftentimes, when I have patients who are coming to me in an adult clinic, in an adult setting, who come with a parent, we will have the parent step out for a portion of the visit, whether it's for, a part of the exam or part of the interview, just to specifically ask about issues that they might not feel comfortable about talking in front of their parents, but also to make sure that there aren't any issues with the patient's safety. And so we often have those conversations with a chaperone present, so a chaperone from the medical side, but that we're going to, say, do the patient's pelvic exam, and they're comfortable doing that with the parent out of the room, having some of that time where the patient is just allowed to ask the doctor whatever they want with their mom or dad out of the room. The other way I've done that is with the more and bigger popularity of the online messaging systems. So again, in an adult setting where patients are able to participate in that. But I think, as far as adolescents go, most, 12, 13, 15-year-olds know more about using the messaging systems than their parents do. So allowing them to ask questions of their doctor without necessarily being face-to-face is a good way of, I always say, ask any questions that you have or anything that you think of that you don't either get a chance to ask during the visit or you don't feel comfortable asking. You can always pose that in the form of an email and send it to some of the provider. We use the MyChart system, but can send that to the providers through electronic messaging systems. One, because that's a lot of the way that patients in the adolescent ages are communicating in general. But two, it's a way that they can kind of, I think, feel that there's some privacy to it. I generally don't see as many patients in that adolescent age group. But I know that we have a lot of people on the pediatric urology team where maybe those aren't questions that they're going to be asking their surgeon that's going to be revising their MACE, but it's questions that they would ask of the nurse practitioner on the team, or one of the other support people through the hospital that works with patients, their occupational therapist, for example, things like that, just to get the conversation open and get directed towards the right resources.
Great, thank you very much. So a related question, how would you recommend bringing up that conversation about sexual health to individuals with spina bifida if they're not bringing it up themselves? And like what age group, at what age would you do this?
Yeah, I mean, I think that, depending on developmentally where the patients are, when we see people who are going through puberty and who are in school with other kids who are going through puberty, I mean, that topic is broached, whether you know it is or not. Very often, that people are talking about that. And so I think it's fairly easy to put blinders on and not bring it up when it's uncomfortable. But I think one way to bring it up is to say, hey, we know this is in your curriculum at school this year. This is 6th grade or whatever the year is that, in your school curriculum that you're going to be having health classes that have to deal with sexual education. Or this is something that we know comes up a lot when people first have menstrual periods, is a good time to bring it up. And so when some of those physiologic changes are happening, patients notice it, kids notice it, adolescents, and parents notice it. And so I think you can either be quiet at that time, or you can start to bring it up, or at least put out some feelers to see if people are open to talking about it and willing to talk about it. And just putting out that, and I think the previous panel, to have the mom that says, just putting it out there that you can ask questions and that we'll give you answers. And I think for parents, being able to use the resource of saying, hey, that's something that I think we need to talk to your doctor about, I think is a great way of keeping that conversation open and getting the kids questions answered that they want.
Okay. Awesome, thank you. Any advice on how to ask a doctor's office that you would need help to transfer to a table for an examination?
So oftentimes in my clinic, specifically, we have, all of my exam rooms are very patient friendly, and this isn't done everywhere, but, all of our doors kind of fit adaptive equipment through. All of our tables are very low to the ground for transfers, and they're all mechanical, electric tables that can move, whether they have adjustable stirrups, backrests, however it works. And then we have staff members who are medical assistants in general, but staff members who deal with patients of different abilities all day. So I have patients who come in, patients with spina bifida, but I also have patients who have had strokes. I have patients who have had spinal cord injuries. I have patients with MS. So, it's not uncommon to have patients that come in that need help. And so oftentimes what we'll know sort of at the outset, hey, this is an exam that we're going to need to do. We sit down, we talk about, all the rest of the visit information, and we do the exam at the end. And so we'll bring back in that medical assistant that, helped get the patient in the room to begin with, and, take their blood pressure and do those kinds of things. So they are familiar with them. And so they know, hey, this person came in a motorized wheelchair. This is what they need to transfer. This is the side of the bed they should be on. This is the arm of the chair and how it moves. These is where the controls are, things like that. And so most of the medical staff is familiar with that. And, what we do, we have them come in and assist us getting whatever we need, whether it's, changing the paper on the table or helping the patient transfer over. Most of the people who work in a urologist's office in general are very open to talking about sensitive topics and are very open to helping patients who need help. So, these are not people who are green and would be embarrassed to be helping patients to do these things. And so I find that the office staff, particularly in urology, you kind of have to have a sense of humor to be in a urologist's office. And so they're very understanding, and most of them have dealt with patients of all varying abilities, who we see every day.
Okay, great. Thank you. What about, are there any fertility implications of having an artificial urinary sphincter placement in males?
So, no, I think that in general, if you want sperm to come out of the end of your penis, you have to have an open channel. So that would mean that the sphincter would have to be opened, either deactivated where it was fixed open, or opened around the time that you were ejaculating in order for the sperm to come out. Otherwise, that sphincter is going to hold tight, just like it holds tight to keep the urine from coming out. It's going to hold tight to keep the semen from coming out. And so that would have to be an individual, if you were attempting to get pregnant through ejaculation and intercourse, that would be something that you would need to do, is to manipulate the sphincter around the time that you were going to ejaculate. Does it decrease your fertility overall? So, it wouldn't change the quality of the sperm or the amount that comes out, or the type of fertility treatments that you would need, other than at the actual physical time of ejaculation, that sphincter needs to be open in order to let the sperm come out.
Great. Okay, we have a few more. So you talked about the options for men who can't become aroused. What are your recommendations for women?
So overall sensation kind of mapping is important, and exploration of the body sensation areas that can give you sexual arousal. And it's not always all the genitals. So there are other areas of the body to explore, but overall things like vibration and vibrators and looking for ways to maximize the sensation that you do have is certainly something that is important, but also then, bringing those ideas up with your doctor to make sure that there isn't some other barrier that's going on. When we talk about patients with different, we said the brain is the biggest sex organ in the body. We'll see patients who maybe could masturbate and have orgasms before, but now they can't. And we look at things like their medication list. And so sometimes they've been put on an antidepressant, and that suppresses your ability to become aroused or have orgasms. There's other medical reasons why people have sexual dysfunction. So we would treat that like any other medical problem. So if you came in and told me, hey, my sexual function has changed, or hey, my sexual function is not where I want it to be, those would be things that we would talk about from a medical perspective. But in general, for figuring out what your capabilities are, what your sensation levels are, and things like that, I think that some of that's just having the motivation and the willingness to do some self-exploration and figure out what you can feel and what feels good.
And we actually had a comment going back to the transferring question, coming from a PT perspective, saying that I have patients that will call ahead of time and they say that they need assistance with transferring, so that everybody's prepared when the patient arrives to make the patient feel more comfortable on the day of the appointment. And then we have one more question, which is prolapse uterus a concern when it applies pressure on the urethra and causes the catheter to bend when entered?
So I think that's probably a very individual question. In general, I have lots of patients. Prolapse is one of my major focuses. And so I have lots of patients with prolapse. In general, when the uterus has come down far enough that you can see or feel the cervix at the opening of the vagina, then part of the limitations of the vagina is like a sock. And if you pull the toe of the sock out, which is where the cervix is, then you start to get some bending or kind of movement of where the urethra and the bladder neck are. And so those structures, even though they're separate organs when we talk about their function, they're actually intimately attached to one another. And so the vagina, the bladder, and the urethra are in very close approximation to one another. And so when one moves, the other moves. So it wouldn't be unusual to see that a severely prolapsed uterus, and to get a uterus that prolapses all the way to the opening of the vagina, that's getting to kind of a higher stage of prolapse. So that's a fairly advanced prolapse on the scale of things. So very advanced prolapse. Oftentimes what we would have patients do who had issues relating to catheterization would be to reduce that prolapse with a finger. So actually push on the cervix, push the uterus back in to straighten that channel back out before you cath. Same thing with someone who's voiding. I see patients all the time who have a little bit of issue with the uterus falling down. It doesn't bother them so much, but it gives them some hesitancy where they can't pee right away. And so pushing that uterus back in, kind of straightening that back out, will make that go a lot smoother.
Thank you very much. And actually, we do have one more question. And then I think after that, we're going to move on just for the sake of time and the program. And the question is, so what's the best way to deal with minimal or no ejaculation in men?
So there's two reasons that men don't see any ejaculate come out. One is that they have that retrograde ejaculation where the ejaculate is formed, it's normal volume, there's a normal amount of it, there's sperm in it, all the fluids there, everything's there, but it just comes back into the bladder because there's not enough tone there, there's not enough resistance that makes it go back the other way. So that makes it go out towards the tip of the penis and come out. So retrograde ejaculation, or not having enough ejaculation, again, in and as itself is not an unhealthy problem. That it doesn't give you infections. It doesn't cause any kind of buildup or blockage or issue. It's really a fertility question. And so if the question is related to being able to have intercourse and have ejaculate come out to get someone pregnant, then there are some things that we can do to try to help with that tone and try to get more of the ejaculate to come out in a forward direction. But oftentimes that would be a time when we would do an advanced type of semen collection in order to use for fertility treatment. So the other reasons why people have less ejaculate come out have to do with the formation of the sperm, the formation of the fluids, the tubes themselves being open, making sure that there's no blockage there. Those are less frequently encountered, but that would be another reason why the ejaculate wasn't coming up and it wasn't coming out fully. And those would all be reasons to see a male fertility specialist. And we have a fellowship trained fertility specialist at MUSC on staff who's fabulous. And so if that was a particular issue with wanting to get pregnant and not having enough semen coming out, then that would be what I would recommend, is to see a fertility specialist. If it's an issue of not having enough semen coming out and just wondering where it's going, vast majority of the time that's retrograde ejaculation. It's going into the bladder, and it's not a harmful condition and not something that we would typically treat unless you wanted a pregnancy.
Well, thank you so much, Dr. Cox. That was really, really informative. Thank you so much for taking all the questions and for taking your time this afternoon. So thanks a bunch. Take good care.
Honored to be here. Thank you very much for the invitation.
Have a nice afternoon.
All right, take care. Bye-bye.
Bye-bye.